have a lot of women and men who are absolutely just terrified of anesthesia. And I have my friend here, Dr. Ayesha McCoy, who's an anesthesiologist, who's going to help you feel more at ease about having your first experience with anesthesia. Welcome to the FitDoc podcast. And I am very excited to have my first podcast in my home, which is my ACPS practice. And so this is our first podcast in my studio. So welcome.
Thank you.
This is Dr. Ayesha McCoy, and Dr. McCoy is an anesthesiologist that I work with almost on a daily basis every week. And she provides anesthesia for my patients in my facility at ACPS. A little background on her is that we went to medical school together. We went to residency together, and we worked side by side, not just in the surgery side. We actually in the anesthesia, and she worked with me in anesthesia as well. And then once we got into private practice, we brought into the practice, what?
5.5 years ago.
Year?
No, it wasn't quite last year. It was more like 2017.
So we've been working together for a very long time. She's taking amazing care of my patients, and I can't thank you enough for that. So,
well, it's my pleasure.
The reason for this podcast is because I hear so many comments from patients of the complete fear of general anesthesia. They're just absolutely terrified. They feel like, I guess the loss of control and not waking up to their family, and I understand the fear of it, but I feel like general anesthesia is probably one of the safest things we do in our society, like driving a car, flying an airplane. I think in the United States, the experience with general anesthesia is a very, very, very safe experience. And so the reason I'm bringing Dr. McCoy into to my podcast is really to share her expertise and hopefully relieve some of your anxiety about it, and maybe squash some of the absolute fears you have about the anesthesia experience. So I'm going to kind of let Dr. McCoy kind of start this off. We're going to kind of go from the basics of like what types of anesthesia. We're going to go into what you'd expect with anesthesia. We'll talk about maybe some myths you might have heard on social media, which is rampant with a bunch of myths, and then kind of what to expect. And so I'm hoping you can make it to the podcast, but I think you're going to learn a ton of information here, and hopefully you can share it, and hopefully help your friends who are scared about anesthesia feel a little bit better about this. So, all right, Dr. McCoy, we're going to start with the first thing is, what is anesthesia? What are the types of anesthesia?
So anesthesia is a spectrum. And as Dr. Morales said, anesthesia is exceedingly safe when provided in the appropriate setting by the appropriate qualified provider. So and the type of anesthesia you receive is dependent on, first of all, the procedure you're going to be having done, and the patient. And when I say the patient, I mean patient factors. That includes patient age, patient's medical history and comorbidities, and health status, and then how we feel that they will handle the particular procedure that they want to have done. So the anesthesia starts with just simple minimal sedation and what we call anxiolysis. Typically that includes just maybe taking an Ativan or a Xanax.
So you're talking about general anesthesia. So
we're just talking about, so just general anesthesia. So anesthesia can start with a range of sedation and all the way to general anesthesia, where an anesthesiologist or a qualified provider induces complete loss of consciousness and complete inability to respond to painful stimuli, which is what most plastic surgery is a completely intolerable painful stimuli. You would not be able to do it awake. So we provide the level of anesthesia to where they don't feel that painful stimuli, they don't react to the painful stimuli, they don't remember that stimuli, but that also means that they are not able to perform certain innate functions on their own anymore, which would mean they would not be able to breathe properly on their own, and their cardiovascular function may or may not be affected and depressed. And the role of the qualified provider is to support those functions. And that is the purpose of their training, and all of the long years of training we do is how to adequately and appropriately support that function. And the support of that function is also very specific to the procedure, and it's very specific to the patient. And That's why whenever you have surgery, you have a provider in the room with you at all times to provide that support in real time as needed. And you are on a range of monitors at all times. So in order to detect any of the aberrations or changes as they take place in real time and provide the appropriate support in that moment in real time. And those perturbations are not necessarily dangerous. They may potentially become dangerous if not appropriately supported. But
so you're talking about like, the heart starts acting funny, right? So it starts beating weird.
It could start beating faster or slower.
Right.
Your blood pressure might start to low. One of the very common effects of anesthesia is it lowers your blood pressure, to varying degrees. And that's why we monitor blood pressure. And depending on the patient and the procedure, how we decide to respond to that is very specific to that moment in time. Some patients, you lower their blood pressure a little bit, they're just fine. Some patients can't tolerate any changes in their blood pressure. And that's very dependent on the patient and dependent on the procedure. So the whole role of the provider is to be taking all of those factors into consideration and paying attention to the monitors and paying attention to what's going on at the moment and providing the appropriate support. If they have to raise the blood pressure, we have medications that do that. If we have to lower the blood pressure, we have medications that do that. If we have to manipulate the heart rate, we do that. And it all comes from the education and the knowledge and the experience on exactly what to do. We have machines and a full array of apparatus to help us manage airway and breathing also at the same time. And your qualified provider would be well versed in how to use all of these devices and machines and to provide the appropriate support. And then at the
I want to kind of elaborate on that one point because I feel that there's a misconception of what general anesthesia is. I feel like I hear it on social media and I hear from patients say, I had a friend of mine who had surgery under local anesthesia and they were able to do liposuction, Dr. Morales. They did liposuction and supposedly they're awake and they remember everything.
Yes, that's happened. When you're awake, you're going to remember things.
And my next question for them is always, did they hurt? They say, yeah, it kind of hurt.
Yes.
Why? Because you're awake.
Because you're not asleep.
Because you're not asleep. So is that general anesthesia?
No, that's not considered general anesthesia.
What kind of, this twilight anesthesia, what do you call that?
So twilight anesthesia is just a common colloquial term for what is more of like what we call conscious sedation or moderate sedation. Right. So like I was saying, anesthesia is a spectrum. It's not like you're okay, now you're on anesthesia, now you're off.
Correct.
It's not that. It's a spectrum. We start with medications that can just simply relax you or medications where you are more asleep than just a little bit of relaxation. You're more asleep. You will fall asleep. But if I stimulate you in some way, like if I touch you or kind of rub on you kind of difficult or kind of yell at you, you may wake up. And so there are situations where that kind of anesthesia, that's what we call conscious sedation. You will respond to a particular level of stimulation.
Examples of conscious of anesthesia. What kind of maybe common procedures that are done in outpatient setting? Maybe a few plastic surgery procedures would be
plastic surgery procedures. So a lot of the things that they do in the office, like if you were just to get some very simple procedure done depending on which part of the body, like some of the lasers and machines we do, you may do some conscious sedation because they may be kind of painful. So we may do conscious sedation a lot of the times in conjunction with local anesthesia.
Right.
So local anesthesia are the numbing medicines.
Right. So it makes it so you don't feel the pain.
So you don't feel the pain. Right. Now the numbing medicines are not 100% either,
Correct.
which I'm sure you have encountered.
Exactly.
So
correct.
all of these, so we may do conscious sedation in conjunction with numbing medicines, and usually we can do some of the more painful lasering. You can do some of the very small procedures on a small area. A non-plastic surgery would be like a lot of dental procedures are done under conscious sedation.
Colonoscopies, maybe?
Colonoscopies, endoscopies, where they'll spray your throat with numbing medicine and then give you some sedation to where you fall asleep, and then they'll look in your throat and stomach. They'll do colonoscopies. And that's one, there are a lot of advantages to conscious sedation, but they still should be provided by a qualified provider. Because in order to say you can perform conscious sedation, like I said, all sedation is a spectrum. it could potentially, if you give too much conscious sedation, it becomes more deeper sedation. If you give too much,
troubles like breathing.
They will start to have problems breathing on their own. Right. Conscious sedation is defined. You are considered under conscious sedation if you are still responsive to stimulation and you maintain your own airway. At any moment, you and I are maintaining our own airway.
Correct.
We don't need anyone helping us to keep our airways open. But if we were to start receiving sedation slowly deeper and deeper and deeper, we would not be able to do that anymore because we would take away that ability with the sedation. While we're taking away the ability to feel the pain, we're taking away the ability to maintain your airway. So if you give a little, and you don't know, it's very, what takes experience and what is the art form of anesthesia is that moderate sedation, conscious sedation, can drift into deep sedation. And it's all dependent on patient factors. It's dependent on a lot of things.
And that's where it comes into a qualified provider.
That's what comes into a qualified provider who must be able to adequately support the patient if they convert into deep sedation. Right. If you continue down deep sedation, then you are where deep sedation is you only respond to painful stimuli. So in deep sedation, you can do more painful things, but if it gets to be too painful, you will start. And that's why you will start responding. And that's why sometimes you will see, people will remember they had a colonoscopy and people were telling them, hey, come on, wake up, take a deep breath, wake up, take a deep breath. That's them stimulating them to try to bring them back into the more moderate sedation.
I understand.
And so
So there's kind of this balance of,
It is a very delicate balance. Right. And, it gets to be people who do it a lot get very comfortable with it. But you should remember that it is not a small thing to take someone's ability to maintain their airway away. That is not a small thing. For a qualified provider who's doing 20 colonoscopies a day, it becomes very, very routine. Sure. And they feel very comfortable with it. And that's the kind of person you want taking care of you.
Right.
But people should not be nonchalant about conscious sedation for that reason. They shouldn't say, I'm just going to get a little sedation, because that sedation can very easily start transitioning into deeper sedation. That's why a qualified individual is always so important, no matter how small or that you feel the procedure is or the sedation is.
It's still a procedure, right?
It is still a procedure.
It's still a procedure.
It is still a procedure. You're still receiving medications that can take away your ability to keep your airway open. And if you continue down that path, will eventually depress not only your airway, but depress your drive to breathe, and will eventually, depending on how deep you continue to go, will depress your cardiovascular system.
I understand.
So it's all a spectrum. It's
little question here is, does conscious sedation involve gas, or does it involve IV medications?
Generally speaking, it involves IV medications on a general sense. It can involve gas, but it's more IV versus gas is dependent on the patient, for one thing, the procedure, where the procedure is going to be done. Gas requires more of a big machine and apparatus that can deliver the gas without delivering it to the entire room. So generally, when they're doing procedures that are just conscious sedation, they're trying to do them quickly. They're trying to do fast. They're trying to do fast turnover and do lots of cases in one day. IV is very easy to do that. You can just carry a little box of drugs around and draw drugs up and give IV medication. You can turn IV medication off and it's off immediately, versus gas. You have to breathe it on, breathe it off. And so for more of logistics, IV tends to be a lot more convenient and a lot more easier. So on a generally speaking basis, it's mostly IV medications, but it can be gas.
So, I got a question actually the other day on my Instagram about IV medications for anesthesia. And is it that Michael Jackson drug?
Yeah, you get that a lot. Like
you get that a lot. Do you get that a lot when you
all
meet
the time. It's like, are you going to give me that MJ juice? And
the MJ juice. That's
the
it.
MJ juice, and they're like, oh my gosh, you use that. And so that is specifically speaking to propofol. Propofol is an old drug, and it is a very useful drug.
Powerful drug.
Very powerful drug.
Very powerful drug.
It is, and it's got a lot of great things about it, but like pretty much 99.9% of the medications out there, it has side effects. But like every drug, the side effects can be to your advantage and they can be minimized, but it's all about the appropriate use by the appropriate person and the appropriate provider. Propofol is an anesthetic. We use it what it does is it causes you to lose consciousness and
amnestic effect.
It will cause you to have amnesia where you don't remember, and it will cause you to have loss of consciousness, total loss of consciousness. It will cause you to stop breathing at higher doses. Okay. So as the dose goes up, as lower doses, it just kind of makes you go to sleep, which is what Michael Jackson was trying to obtain, because Michael Jackson had severe insomnia. So what he was using propofol was to sleep. Well, as I was stating earlier, sedation is a spectrum. So if you start to convert into deeper sedation, propofol at higher doses, or it starts to build up into your system, if you're not clearing it fast enough, the doses get higher in your system, it will convert you into deeper sedation and take away your drive to breathe, and you won't breathe, which is what happened to Michael Jackson. He was overdosed on propofol.
By an unlicensed provider.
And it was being provided by an unqualified provider in an inappropriate setting on top of that.
Right.
I want to be with full disclosure. I don't know all of the details. I don't know if he was on monitors or not or anything like that. I don't know what that doctor's qualifications were. I'm almost positive he was not an anesthesiologist or a nurse anesthetist or anything like that. So I don't want to speak to the specifics of that case, but I do know a lot about propofol. And I know that handled in the appropriate setting by the appropriate provider, it is a very useful drug that you want to be using.
It's one of the most common.
It is one of the most common
we use in the United States, correct?
Right. It is a very common drug.
Is that just a United States thing, or is it a world
thing?
No,
it is a worldwide used drug. It is a very safe drug used properly. It is a very useful drug. It has a lot of good things about it. It puts you to sleep very quickly. It helps you relax. It actually has an anti-emetic effect, helps with nausea, and has a lot. We use it a lot at ACPS, and I've used it rampantly at many institutions all over Houston.
Right.
And we are trained on it, and all of the facilities all over the United States train on it. And there is no reason to be afraid of it if it is being used by the appropriate provider in the appropriate setting. It's absolutely no reason. And there's very few drugs that you can substitute for propofol. If someone has a true allergy that you can't use propofol, there are a few other options. There are I shouldn't say there are other options, but they aren't quite the same. They're not quite the same.
So and we could talk about the different types of anesthesia for a while, but I want to kind of focus more on the general anesthesia, because this is what people are, it's for what I do in plastic surgery. In my practice, all I use general anesthesia. I will not do my procedures performed under local anesthesia or conscious sedation. I just feel it's safer. I just feel safer having anesthesia provided by someone who's an expert in it, Dr. McCoy. And so that's the gist of where we're going. So general anesthesia and what kind of facility is provided. Let's talk about that, because I feel like, you start hearing these horror stories. I hear these horror stories of I had a procedure done in my doctor's office, and tell me about the office where you had it, and where was the facility? Oh, it was just a room in the back. It was basically a closet, sound like, with maybe a machine, and it's really kind of disturbing to me when I hear some of these horror stories of what kind of facilities, quote unquote facilities, or quote unquote accredited facilities of where they're having these procedures. And so let's talk about what kind of facility you should expect to have general anesthesia. Would you consider a gold standard, and what is that minimum required for a facility?
Well, so a gold standard facility should have a place, so it should be fully equipped to handle an emergency situation. Okay, so an emergency situation under general anesthesia would be so the worst case scenario, what would be the absolute worst case scenario would be a code blue, right? So someone who needed to be actually receive CPR and be resuscitated. And then that person would likely have to be admitted into a hospital, right? And have other services available to them, lab services, x-ray services, and, other specialty services that they may need. If they needed a cardiologist to come see them, pulmonologist or something like that, or they would have to be in a place that they could be monitored, like an intensive care unit. So that would be the gold standard place. So you can make an argument that the gold standard place would be a hospital. And a hospital, but when the hospital is a gold standard place for a patient that is not appropriate for an outpatient surgery center. So when you want to talk about a gold standard place, you could say a hospital would be a gold standard, because a hospital has a full range of services. You can stay overnight, and it has an ICU. Right. Now, but practically speaking, the reason ambulatory surgery centers have become so popular, because they actually are better than hospitals in a lot of ways.
Okay.
And
ways?
They're better in that they're much more highly efficient. In they can do a lot more surgery in a lot shorter time, simply because they are not a hospital.
Right.
Simply because they don't have the machine of the hospital to deal with.
Right.
They have a lot lower overhead. Their cost to the patient is generally significantly less. So as I have probably said a couple times, which one is the gold standard? It depends. It depends on...
It's one of your favorite words.
It is, because there's no clear cut. It depends on the procedure you're having done and the patient. So that's where, again, your qualified provider comes in. We come in and we say, okay, you are having this procedure. You are this kind of patient. A hospital is a better place for you to receive your general anesthesia. And so when you come into the hospital, you should expect a place that can provide all of those services. But if your provider says, okay, you're having this procedure and you're this kind of patient, an outpatient surgery center would be better for you. And outpatient surgery centers have a lot of advantages besides the fact that they're cheaper and they're more efficient. Outpatient surgery centers become extremely well-oiled machines to their craft. Such as ACPS is a perfect example. The ACPS does only plastic surgery and just plastic surgery 50 times a day between all of our operating rooms.
Right.
So as they do it all day. So you could make the argument that it's become a very well-oiled machine for plastic surgery. Mm-hmm. Now, the ambulatory surgery centers, you should expect a certain standard from them also, though. That doesn't mean that they are held to any lower standard. No, they are not a hospital in that you can't be admitted to an ICU.
They meet a ton of accreditations by
they
state
still
and
have to
private
be
organizations.
still have to meet accreditations. They still have to be able to provide a certain level of emergency services. We always have a crash cart involved, a crash cart there. We have a way to obtain x-rays if we need them, and every surgery center should be able to transfer to a hospital. They should required to be able to transfer to a hospital in a timely fashion. And also the place should be staffed by qualified providers. So at ACPS, if the worst were to happen, you are surrounded by qualified providers that can provide resuscitation. We have privileges to transfer to a hospital if needed. We have ability to provide x-ray and to do all of those emergency services. So if you can find, ambulatory surgery centers, you should expect those standards also. They should have all of those things. So as far as the gold standard, they both have different things about them, and like I said, it depends.
Depends on your type of procedure.
On the type of procedure and the type and the patient.
Right.
The patient. If the patient has a lot of health problems and is not the healthiest, a hospital is a much better place for them than a surgery center.
All right, so we kind of gone over the types of anesthesia, what kind of facility a little bit. Who maybe can answer better in the ambulatory setting versus maybe in the hospital. So it kind of depends.
It all depends. It all depends on
Right.
the type of surgery and the patient.
Right. So now we're going to kind of talk to people who are kind of what to expect, right? So how do I get ready for my first anesthesia experience? Like, do I need to eat different? What I need to do to sleep? Like, how do I prepare? I don't know how to prepare. How do I prepare for my first anesthesia experience?
Okay, so to prepare, first and foremost, if you are a smoker, it is never a bad time to stop smoking. So, I'm never going to tell people, no, don't stop smoking. And if you can possibly stop smoking at least 2 weeks to a month before your anesthesia, that will be very advantageous for you. I know that's a lot to ask for a lot of people. But
the smoking itself is not really the nicotine, which I can talk about more about surgery. But
yes, it's the smoking yourself. It is the irritant to your lungs and airway. If you can, the longer you can go without having that exposure to your lungs and airway, the better for you. Yeah. Because then you're coming in with far less inflamed airway and lungs.
I've got someone on the camera most likely asking this question right now.
Really?
Does vaping count?
Yes. In my opinion, it does.
Because it's so rampant now. Like everybody vapes and no one considers it smoking.
It's true. Every time I ask, what kind of smoker, people say no. And I'm like, well, are you vaping? And they go, yes. Vaping has not been around as long as cigarettes, so we don't have the long-term studies that we have with cigarettes, but I'm sure they're coming. Yeah. I am sure they're coming, and you're not going to be able to convince me that it's less healthy or not as bad as cigarettes.
Thank you for saying that, because I tell my patients the same thing when we start talking about, like, what do you smoke, and I'll vape, or I smoke marijuana. Does that count too? And
yeah,
it's all the same, right?
Inhaling any irritant like that is gonna cause damage. It's gonna cause inflammation and irritation to the lungs and the airway. Yeah. And when you're going under general anesthesia, which, like I spoke to earlier, it does depress your drive to breathe, depress your airway. We have to, be supported by your provider. You want to minimize any sort of inflammation and irritation to your lungs and airway. So if you can at all stop, it's never a bad time. It's never a bad thing.
Always safer.
It is definitely safer. Right. It's definitely safer. So if you are a really bad asthmatic, any type of health problem you have, asthma, blood pressure, if you can get that consistently under control for as long as possible, which is just good for your health anyway.
Sure.
That will go a long way to make sure your anesthesia goes smoother. Mm-hmm. Okay, people who have uncontrolled blood pressure, their blood pressure will go up and down, which is never a safe thing. Mm-hmm. You want to try to be as controlled as you possibly can. If you have asthma, if you need to be on regularly scheduled medications for that and try to get your asthma under control, that would be a safer thing for you to do. So speaking to more like, those are more general long-term things you can do. But closer...
Well, let's talk about why it's so important for the airway, because for general anesthesia, we typically control the airway.
Yes.
In a couple forms. What I know as a plastic surgeon is they use a tube, which goes all the way into your down your trachea. There's another version called the LMA, which is called the laryngeal mask airway.
Yes.
Which is like this little cuff that kind of goes in the back of your throat. So both of those, the purpose of it is to control your airway.
It's to support your airway.
Support your airway.
Yes.
So both those versions, can you kind of elaborate on those?
So we have. So those are kind of the two major general ones we have. There is what we call an endotracheal tube, which the anesthesiologist applies down the trachea and in between the vocal cords. And they inflate a balloon just under the vocal cords.
Keep it from popping out.
So that it doesn't pop out. Mm-hmm. And while you are helping the patient breathe, it is going directly into the lungs, and it's not coming out around and going down into people's stomachs or coming out of their mouth or anything. It is the way that we can 100% absolutely control the airway and the breathing of the patient. Okay, and we can isolate the airway. We can isolate the lungs from the rest of the body that way. And it is, I don't want to say it's safer than an LMA, but it's just different, and it is appropriate in particular settings, especially at ACPS when we're doing liposuction. We have to turn patients this way. We have to turn patients that way. We have to, when we are doing BBLs and we want to go onto their tummies, we have to turn patients this way and that way. Just like anything else, you don't want to be putting an airway in and then it accidentally be coming out because we're turning the patient around and things like that. The endotracheal tubes are a little more secure in that aspect. They stay in place better as long as you're careful and people are paying attention. It's safer in that aspect. We can provide even a very, very deep level of anesthesia with endotracheal tubes because we have isolated the airway and we have full control over it. So if we need to move people around, we need to keep them very, very deep for surgery, we're able to do that with endotracheal tubes. Laryngeal mask airways, or LMAs, are masks that sit on the very back of your pharynx, on top of your airway. And if you know anything about your tracheal anatomy, and your trachea is where your esophagus and your not in your trachea, excuse me, in your pharynx is where your esophagus and your trachea separate from each other.
So it's deeper than your tongue.
It's deeper than your tongue.
Right.
It's past your tongue.
Past your tongue.
And
past the point where your esophagus and your trachea split, correct?
Yeah, it's a little bit past that.
Correct, yeah.
And it is a little bit on top of your esophagus. It is on top of your esophagus. So, and what it does is, what it helps us with is as people are going under anesthesia, when we say that they start being unable to support their airway, is what we're talking about is your trachea and your pharynx is just like anything else. It's muscles.
Right.
It's all a bunch of muscles. Okay, there are not really many bones in here that keep you open. It's a lot of muscle and what we call soft tissue, just soft stuff. And so as your anesthesia gets deeper, those muscles, like the rest of your body, start relaxing. And so as they relax, they start closing up, and you hear people like making really loud snoring sounds, because that's their closed soft tissue rubbing against itself and closing up. And it's the same concept of people with sleep apnea. People with sleep apnea,
So they stop breathing.
They stop breathing.
Yeah.
They start snoring super loud because their airway's closing up, and that's why that's why they use a CPAP machine that helps keep their airway open. Instead of using a CPAP machine, which only works to a certain extent, we are using a laryngeal mask airway. We're putting a mask in there to hold that open, and we can deliver anesthesia through that. The patient can breathe through it on their own, or we can help them we can assist them with that also. It's a very useful tool. There are a lot of different uses for it. Sometimes there are people out there who are extremely difficult to put an endotracheal tube into for various reasons.
Mostly anatomical?
Mostly anatomical. It could be their trachea is in a very difficult position. It's very difficult in order to put an endotracheal tube, you have to be able to visualize to some extent the vocal cords.
Right.
That in order to visualize that, we use tools, a lot of different tools to visualize that, and it takes practice, and that's what you do in your training, is learning to become good at visualizing the vocal cords. But there are people out there that you cannot visualize their vocal cords for whatever reason. People who are extremely obese, people who are just the way their anatomical layout is, people who have had any sort of surgery prior, radiation, accident, anything like that.
Pretty rare, though.
That is pretty rare.
I've seen it twice at ACPS.
At
We
ACPS,
just couldn't do it. We just couldn't do it. And we had to we just stopped right then and there.
It is very unusual. If you have an experienced provider, it's going to be very rare that they can't get the endotracheal tube. But if they can't, the other thing is that someone who's just receiving sedation, and if they convert into a deep and they're not able to support their airway, the part of the ASA algorithm for obtaining the airway on an emergency basis is to be putting an LMA. So an LMA is a part of the emergency airway algorithm. It has a place. It definitely has a place, and it's very useful. Now, for ACPS and for our surgeries, we make the decision on which one to use depending on the surgery, how long the surgery is going to be, and the patient, the patient. As far as the patient's experience, it's probably not going to be very different. An endotracheal tube can cause a scratchy throat. It can cause a sore throat. On the rare case, there is always the possibility of causing vocal cord paralysis.
I think I've never heard of that.
It can happen. It does happen. It's very, very rare if there's an experienced qualified provider that's being gentle and not being very violent and not being violent about it. It's very rare. But just like anything else, it is considered a very small procedure.
Sure.
So things can happen. But, I come back to, as long as you have a qualified provider doing these things, it's extremely safe. And having an endotracheal tube or an LMA in place is far safer than not having one when you are under anesthesia.
Yeah, I couldn't agree more. Well, let's talk about maybe eating. Like, why is it so important not to eat, the morning of surgery? Because you've done these with me. We've canceled a patient because they decided to drink coffee the morning before surgery. I'm like, well, it's not food. It's just a little coffee. Well, how much coffee do you drink? I drink, half a cup. No, why
Yeah.
is it important not to eat before your procedure?
I get that all the time, and then patients
Why
get.
is it so dangerous? This is what people don't quite understand. It's so dangerous to do that.
So you really.
So don't lie to your anesthesiologist.
Yes, please don't. And don't lie about your kid's status either, please, if they're getting anesthesia, please. So it's you want to have an as empty of a stomach as possible. Okay, you want your stomach to be absolutely empty, because when you're going under general anesthesia, there is always the possibility that you will vomit, always. And it doesn't matter how many drugs you get and how much we try to prevent it, it is always a possibility that you could vomit. And the vomiting itself is not the bad thing. What you don't want to do then is that vomitus to get back into the airway and get breathed into the lungs. That stomach contents is extremely irritating and inflammatory to the lung tissue and can cause a whole host of problems. Right. Will you die? Most likely not. Very, very rarely. But could you have a lot of problems? Absolutely. Yeah. Could you have mild problems? Could you have no problems? Yeah. Maybe not. Could you have some mild problems? Maybe. Could you be in the ICU for months? Possibly. So that you want to have an empty stomach as possible. So we tell people no eating or drinking 6 hours before. And usually it's after midnight the night before. Correct. For adults, we just say after midnight the night before.
Correct.
If there is someone who is a horrible diabetic, who cannot tolerate not eating or can't do that, we can adjust that schedule on very individualized basis. For children, we're a little more flexible, and we're a little bit more flexible with no solid food for 6 hours, and they can have clear liquid, which really truly means a clear liquid that you can see through. Right. You can up to 2 hours before. For adults, we say no eating or drinking after midnight. And that is a very good way to make sure that you have an empty stomach. It doesn't matter. And the thing is, it's not, and then I get the question all the time, okay, I get that, but all I did was take a few little sips. Right. So those few little sips of coffee you took stimulated a whole rush of hormones.
Sure did.
And it stimulated, you hadn't eaten since the night before, and then you drank some coffee, and your stomach's like, oh, okay, breakfast is coming. It's time for breakfast. And your stomach started filling up with gastric contents, gastric juices, started moving around, getting all ready. And now we're going to go under general anesthesia. Right. So now your risk of vomiting's probably gone up a little bit. And now, even though you drank this much coffee, it's filled with this much gastric contents that's full of acid.
Waiting for breakfast.
Yep. And it's full of acid and enzymes that, if on the rare chance gets into your lungs, all that's is gonna it's very, very caustic to lung tissue.
You're basically pouring acid down your lungs.
Yeah,
that's basically what it is.
You're pouring your stomach acid into your lungs.
Not good.
That's not a good situation at all. And so, as uncomfortable as it is to skip breakfast, it is very well documented on how much more safe it is. Yeah. And so it is just a hard stop. It is a hard stop.
Not worth it, people. Don't do it.
It is not worth it. The only time that I have ever negated the eating status of a patient was in a true emergency, to where we weigh the risks and benefits. And in the case of plastic surgery, it's an elective surgery. It's not an emergency surgery. It's not life-saving surgery. There is no reason to add to the risk that way.
Absolutely agree. Just not worth it.
It's not worth it. And so just skip breakfast. You'll get an IV. We'll give you some water. Nobody leaves us dehydrated. I've had this many patients starve to death. And
I mean, you know this. I work with a lot of athletes, and they think it's the end of the world. I haven't eaten. You don't understand. I'm so hungry. I had to eat something. No, you don't.
You don't. I've not had any. I have not. None. No, I've never had a problem. I've never had a patient have a problem from not eating. I've never had a patient get dehydrated. I've never had any problem from not eating or drinking.
Totally agree with you.
It's always the reverse.
Yeah. All right. Next topic. Ready?
Yes.
Patient says, I'm allergic to Tylenol. I'm allergic to lidocaine. I'm allergic to fentanyl. I'm allergic to Vicodin. Well, what happens when you take Vicodin? What's the common answer you hear?
I get nauseated. And if you look at If you ever received Vicodin from the pharmacy, you know when you get medication from the pharmacy and they give you a book of information to read?
Yep.
If you ever look at Vicodin, like the very first side
line.
effect listed on there will cause nausea.
Right.
Take with food. So it's a very common misconception, you know, and we laugh about it, but you know, it causes distress to patients because they think they have an allergy and they think that they could potentially like have a really serious problem.
You're right about that.
And
they do feel like it's something that's really caused anxiety. And
yeah, it's very anxiety provoking for them.
Sure.
So there's difference. There are side effects, and which can also be called drug intolerance and allergies. So side effects.
So let's talk about the really scary allergies.
So the scary allergy, an allergy involves when the immune system is triggered, okay? When there is a component, it's usually, and generally an allergy to a drug is not necessarily to the drug itself. It's usually to like a dye in the drug.
Or some kind of component with
or some component of the drug. You know, because when you take a drug, you're not just taking the drug. You're taking the stabilizers and the preservatives and the dyes and the other things that that you have to use in order for it to be what it is. And so an allergy is when the immune system is triggered.
And it overreacts.
And it can be what you consider, it can be a rash, it can be hives, it can be, flushing and dizziness, and then, or the worst case scenario, like a full-on anaphylaxis where you have complete collapse of your cardiovascular system. That is extremely rare.
Right.
And so I want patients to first understand true anaphylaxis to drugs is very rare. Very rare. Right. Also, I would like patients to understand that because your family member had an allergy to a drug is really not indicative that you're going to have a problem with the drug.
Right.
I want to put that out there. Okay.
Great. I didn't know that.
Yes. I have so many patients that come and tell me they have on there that they have an allergy to a drug. And I said, well, what happened when you received that drug? I don't know, but I know my mom is allergic to it.
Very common statement with antibiotics.
My mom's allergic to penicillin, so I just put that I'm allergic to penicillin. Right. So, true allergies are pretty rare, but they do happen. And as far as anesthetic drugs, the most common are to what we call neuromuscular blockers is the most common allergy. And even that is very rare. And then it's antibiotics. Usually, and most allergies to antibiotics are usually like a rash and itching and hives. Does it mean that you should never ever receive the drug again? You know, that's up to debate a lot. There's some patients that think there are docs, and I am not an allergy specialist, but there are people who think that if you have a mild allergy, that maybe one day it could progress to a big anaphylactic allergy.
Like your system being sensitized?
Yeah, you become sensitized to it, and then if you receive it again, you'll have a full-on reaction. But what is much more common are what we call drug intolerances. And drugs, what happens when you take drugs, especially when you take the drug and it's in your system, it's working on what we want it to work, but it can start working on doing other things too. And whether and how much those other things cause upset is very patient dependent. Like we have how many patients take Vicodin and how many patients get a little bit nauseated from it, but then how many say, oh, I can never take it again because I was just so nauseated from it. So it's very, how we metabolize drugs is highly variable. Yeah. It's all dependent on like genetic differences among us that will depend on how we metabolize a drug. If we metabolize a drug slightly slower, then there are going to be components of that drug that are going to build up. Then that drug's going to start doing other things. It's going to start making you nauseated. It might give you a little bit of a rash. It's going to start making you dizzy. It's going to start making you tired. It's going to give you a dry mouth or something like that. It's going to start having side effects. How well you tolerate those side effects is very patient dependent. If I take Vicodin and I'm like, well, you know, it makes my pain so much better, I'm willing to be nauseated, then take Vicodin. If it's making you so sick and you're so miserable and the pain relief that it provides is not good, is not enough, not worth it, don't take it.
Sure.
Or try taking it with food. And so people take it with like a little bite of something dry. So drug intolerances are very patient specific. There are a lot of drugs that are very notorious for causing intolerances, Vicodin being one of them. Phenergan is another one that has a lot of, it'll wipe you out for like
Norco
is another one.
Any kind of narcotic pain medicine, I think.
Narcotic pain medicines are notorious. They have a lot of side effects. Have lots of side effects. So how your tolerance of them is very patient specific, but it's not truly an allergy. But all of these things are things that you should discuss with your provider. You should tell them, I took Vicodin and I had rip-roaring horrible nausea. And so then we can do other things, and so you should discuss all of these things, but you shouldn't just a blanket. It's not a good practice to just say blanket, I have allergies, because then you are really causing a lot of limitations on yourself for drugs that potentially could have a lot of therapy for you. So, so it's just advantageous that any sort of bad experience you've had with a drug, to just discuss it with your provider and come up with a plan of how we can work around that. I've had patients that we've discussed things with, and we've discussed different drugs with that they didn't like, and then we come up with a plan that really works with them. And sometimes it has involved drugs that they have said they can never ever have. And when we've talked about it, I'm like, well, I don't think that that's really the case. And maybe if we did these and this things, this might actually work for you. And a lot of the times it turns out just fine. So it's all things that need to be discussed, and that's part of the job of your anesthesia provider. You tell them, I took this drug and it was horrible, or I took this drug and, they sit there and tell you, my mom's allergic to penicillin, so don't give me penicillin. I'm not going to force the issue. I'm not going to force people to be like, no, you're fine. You need to get penicillin. But it's just part of the education that they can receive, and education's always good. Having more information is always a good thing. Sure. So it's just any sort of question you have about a particular drug, bring it up with your provider, and we can talk about it.
All right, so let's kind of going through maybe the anesthesia experience when a patient gets in the pre-op room. Let's kind of accelerate it forward. They got their IV done by the nursing team, kind of in a gown and everything like that. And now you're sitting in this chair just waiting what comes next. So usually the first person that's going to come talk to them is going to be
your anesthesiologist.
So what should he expect? What should he expect when you have a conversation with your anesthesiologist?
Well, you should first expect them to introduce themselves. Mm-hmm. And then they are going to start asking the patient. They're going to start asking the patient questions about themselves. Yeah. They're going to want to verify the eating status.
Right.
They're going to want to verify any health problems they may or may not have. Part of the anesthesiologist's job is what we call perioperative planning. We do review patients' medical history before we see the patient, and we have to talk about their medical history. Does anything need? Usually beforehand, we decide if any intervention needs to be done. But at ACPS, that's very unusual. Yeah. So when we come in, we ask them about their medical history. We ask them, do you have anything? We ask them about their airway. Do you have anything in your mouth that can come out, like retainers and dentures? Those are all things you need to know that you have.
I had a patient the other day. I had a tooth that just can come in and out.
Yeah.
And we didn't find out just because I was talking to him and actually fell out while he was talking. I was like, you're going to tell me you had a fake tooth? He's like, oh, well, I didn't think it was a big deal. And he's like,
well, that's the problem, because then once you're asleep under general anesthesia, then if you have very expensive dentures or retainers, and we realize that all those things cost money, you don't want them to get damaged. You want them to get lost.
You don't want to fall down your airway. That's like the big thing.
Yeah, and you don't want them to get pushed down into your airway or they get broken.
How do you get it out?
I've had it where I've put someone to sleep and then I'm about to secure their airway and their teeth just like come out of my hand. And I'm like, well, I know they spent some money on these dentures, right. So now it's incumbent on me to take care of their dentures. Right. And so, but the main aspects of your interview are going to be about your health and any previous anesthesia experiences you've had. So that's going to be a main part of the talk. Have you had anesthesia before? Did you have any problems with it? And then like we got back to, any medications that you have issues with. And those are all questions that they should be asking. They should be asking, have you had anesthesia before? Did you have problems with it? Tell me about the problems you had. What did they say about that? And those are very important questions that we need to know. And then, when we go through the allergies, what happens when you get those things? Then we can figure out, okay, does that patient has drug intolerance or did they have true allergies? Those are very different things, like we've already discussed. So that's going to be the main component of your interview. And if they don't ask you those questions, then that's a little bit of a red flag.
Yeah, you start getting the red flags.
Yeah.
So here comes, I guess, the money question that I get a lot of anxiety from my patients. When I tell them I'm going to be using general anesthesia for the surgery, and they're like, Dr. Morales, I have young kids. I have, I have young kids. Am I going to die? Am I going to die, Dr. Morales? You can't let me die. And that I understand it. I have kids myself.
Yeah.
And you're doing something, that you don't have to do. It's cosmetic surgery, and I get it. But let's give them the real talk, Dr. McCoy. Let's give it to them. Or am I going to die during my anesthesia?
They're not going to die. Okay, they're not going to die, especially at ACPS. And I'm going to speak specifically to ACPS. We do a very rigorous patient, like we said. Part of the anesthesia provider's job is what we call perioperative planning. Okay, we look at the procedure, we look at the patient, and we decide what is their risk, what kind of risk are they, and then that gets into what we talked about previously. Okay, if they are high risk, do they need to be done at a hospital? Right. Can they be done at an ambulatory surgery center? Are they is this an appropriate procedure and patient for our facility? Because we don't want bad things happening at our facility either. Right. So I want to put patients' mind at ease. We have no interest in putting inappropriate patients to sleep and causing
worth it.
It is not worth it to us. Not worth it. It is not worth it to us in any way. Yeah. So that is part of the anesthesiologist's job, is we call perioperative planning, and we assess risk. So after we go through that process, and after all of the surgeons at ACPS, they go through a process. If patients meet a particular criteria, they are done at the surgery center. If they have particular things about them, age, weight, certain medical problems, then the staff here gets the anesthesiologist involved and say, okay, we need you to look over these patients. Are they appropriate patients?
That's where it comes in, like the medical clearance.
And then we decide, okay, they need to do this, they need to do that, or no, they're fine, they can be done, or no, they cannot be done. Those are decisions that are made by the qualified providers. So going through that process, the patients are deemed appropriate for our surgery center and for that procedure, then your risk has been deemed extremely small. Your risk of having, and now when I say risk, it's not death necessarily. It's having any sort of major complication 30 days out. So that if you have been assessed and deemed appropriate for the surgery center, then it has been assessed by qualified providers that your risk is absolute minimal. And when I say minimal, it is minimal. It is far more dangerous driving to our surgery center than it is.
Especially in Houston, Texas.
Yes. Our surgery center in specific, because you're right there on I-10. Right. It's far more dangerous driving there than it is going under anesthesia. So if you've made the decision, you're going to have your procedure done, and you have gone through the appropriate process by our qualified providers, and we've deemed you an appropriate patient at our surgery center, your risk is extremely minimal. And if you have decided you're going to have this procedure, this is the way to do it, by our providers under general anesthesia. That is absolutely the safest way to receive the procedure. Absolutely. That way you can work, you can do what you want to do, and you can give the patient the absolute best outcome that they can get while they are being kept safe by one of our qualified providers. Right. And so, in my professional opinion, it is the absolute safest way to receive plastic surgery. If they're going to other surgeons and saying, oh, we're safer because we just do conscious sedation, right, or we are just doing sedation, you're not, so we're safer. I already spoke about conscious sedation. You need to be asking a lot more questions then. You need to be asking, well, who's doing that conscious sedation?
Actually, I mean, I've had patients come, I just had one yesterday actually come in and said, yeah, I've had the surgery done before. it was liposuction, did it in a surgeon's office, and the surgeon was providing the anesthesia with IV sedation and having a nurse, adjust the medication during the procedure. And it didn't sound like there was any kind of airway control, but, you're asking, can it be done? Yes, I know it's being done in the community, unfortunately, but there are surgeons who have a lot of experience, performing some of these procedures, while at the same time providing anesthesia for the patient. And for me, I'm just not that good. I don't think I'm comfortable doing that. I feel much comfortable with someone that has the accreditation experience and does this literally every day, all day. Like, to me, for my patients, I assure you're going to get the safest experience possible. And so for me, my providers is always going to be a group of anesthesiologists we work with. And so, Dr. McCoy is one of these amazing providers that we use.
I agree. It is done out there where the person performing the procedure is also doing the sedation. And there are settings, like when we're doing small procedures and the lasers and things like that in the machines, that it is appropriate and it's perfectly safe. There are nurses that do provide sedation. I think they do a small amount they do some sort of training and to do that sedation. And it's appropriate in specific situations. It's appropriate. I know that there are a lot of plastic surgeons out there that do that. I'm sure that they get pretty good at it. But like I said, I would not want that to be done on me.
Why? I mean, let's go, but why?
Probably because it's cheaper, because they can charge less if they're doing that.
She said it, because it's cheaper. And that to me is not the reason. To make more money from a procedure, to me, it's just not worth it. That just concerns me that it's, and these are horror stories I've heard before, right? Patients getting in a lot of trouble.
Yeah.
End up in the hospital setting. But,
well, like I said, it's a spectrum, and you start drifting, and if you don't, and if someone is performing liposuction and they're not necessarily paying attention, I know dentists do it a lot, but dentists and oral surgeons, they do separate anesthesia training.
Correct.
They receive special anesthesia. They don't They don't do 3 years of anesthesia like I do, but they do several months of anesthesia, and they get very, very good at it. They receive formal anesthesia training, so I feel are much more qualified to do it. But even to a certain, they will only do to a certain point before they will call in a qualified provider. Yeah. So But generally, I think it's done because it's cheaper. You don't have to have all of the equipment. You don't have to hire me. Agreed. And you don't have it's just all around cheaper. So then they can pass that savings on to the patient. But in my opinion, plastic surgery is definitely you get what you pay for.
You're so right about that. So I got another question that I get, not infrequently is I think that some of the more savvy patients who've done a lot of research, they say, well, who's going to be doing my anesthesia? Is it going to be a CRNA or is it going to be an anesthesiologist? I had one patient who was pretty savvy enough to say, so how many doctors are overseeing the CRNAs at your facility?
That's a good question.
The answer in that is I don't use CRNAs in our facility. We actually use anesthesiologists for every patient who's with one patient 100% of the time, the entire time. So, I thought that was a great question, very insightful, because she's had procedures before. Yeah. And she's probably met a CRNA, which is what? What is a CRNA?
So a CRNA is a nurse who has gone to they call anesthesia school. They have received a formal anesthesia training after nursing school. So
not residency.
Sorry?
It's not a residency.
It's not a residency. So an anesthesiologist is an individual who has gone through medical school, received an MD degree, and then gone and participated and completed an anesthesia residency, which is minimum 4 years. Right. And then they may or may not go on to take the American Board of Anesthesia board and become boarded, which all of us at ACPS are boarded. Right. So that's an anesthesiologist. A CRNA is a nurse. Now, since I think the late 90s, so CRNAs came around, I want to say in like the 50s or 60s, because there was developing a shortage of anesthesiologists. And this model of anesthesia became this anesthesia care team model, where they started training nurses to provide anesthesia under the supervision of an anesthesiologist. And
they have to be overseen by an anesthesiologist.
Yes, correct? That was the original intent.
And so now what is it now?
So CRNAs have evolved they have a very powerful lobby for one thing, that's much more active than the physician's lobby. I'll tell you that. So, that in the late 90s, they have to have a BS degree in nursing, since the late 90s, and they have to do a year of critical care as a nurse, which is either in the ICU or trauma, I believe. So they have to do at least a year of critical care, and then they go on to an anesthesia program, which I think is about 24 months, I want to say, is 24 months of anesthesia training. In the state of Texas, it is, and so their scope of practice is very state dependent.
Yeah.
In Texas, they have...
Surprisingly.
Yeah, it's very state dependent. And Texas, they have a large amount of independence because there is a very large underserved population in Texas. There's a shortage of anesthesiologists in Texas.
Great word. What does an independent mean?
So independent means that they don't necessarily have to be supervised by a physician in Texas.
They're providing anesthesia.
They're providing anesthesia of their own accord, completely
and so
independent.
The state of Texas, their license is able to accommodate that?
They are, yes, in particular situations and in particular facilities.
Interesting. I didn't know that.
Yes, they can act independently in Texas.
I didn't know that was in Texas. Interesting. Okay.
So in big hospitals,
it's just limited to certain, I guess, areas of Texas, or is it?
I think it's limited to the facilities that they have.
Interesting.
So, and it also comes back to a lot of like reimbursement. You know, you get insurance reimbursement and what insurance will pay for, what Medicare will pay for. So that starts to play a role into things. Typically, though, in big facilities like Memorial Hermann, St. Joseph's, and those kinds of places, the vast majority of providers are going to be CRNAs.
Right.
And just simply because there are just not enough anesthesiologists out there. And generally, an anesthesiologist can supervise up to 4 CRNAs. The anesthesiologist has to be immediately available, which means that they are in a close enough physical proximity to where they can at any time come and reestablish a physical relationship with the patient and provide any sort of support that they may need to. Yeah. That's the standard set by the ASA. But it's very facility dependent. And that's
the same. I mean, we both work in many facilities over the course of our careers, but the facility I've been in, I've worked with a lot of CRNAs, a lot of amazing CRNAs. I'm telling you, they're amazing. I feel very comfortable with my patients, but the anesthesiologists, in my experience, pop in and out, just kind of come in. They're there for induction. They kind of pop in and out during the procedure, and then during the wait, they typically kind of come in and kind of, there's extubation and patients are waking up. So I've never had any issues on the outpatient setting. I've never had any bad problems happen with that experience for mine. But some facilities do use them, correct?
Oh, vast majority of facilities use them.
Yeah. And we're kind of rare, don't you?
We are very rare. ACPS is very unusual, and it's one thing that I'm not going to pretend that I don't love it about ACPS. I mean, I love that we only use board certified anesthesiologists. But there is a shortage of anesthesiologists, and there are a lot of facilities, and you can pay them less also. So that's another, and that's not a small thing. So, but CRNAs are just like anybody else. There are really great ones, and like you said, I've known some amazing ones, and I've known a lot of CRNAs that have a lot of experience. I've known CRNAs that have been doing anesthesia 30 plus years and have taught me a lot. I've learned a lot from CRNAs. And then there are some that are horrible. And
I've had both experiences. I've had anesthesiologists. I'm like, there's just no way I would ever have any.
Yeah, there are horrible anesthesiologists out there, and, just like there are horrible plastic surgeons out there.
You're right. You're absolutely right. We're not all made the same.
No, they're not. So but there is a difference. CRNAs are not anesthesiologists, and ACPS has chosen to stick with board certified anesthesiologists. And I think that I don't know that you can do anything else to be more safe, and especially our specific anesthesiologists are really. And
I'll elaborate on that because I know I'm going to have some people watching this podcast that are CRNAs, and I'm not trying to make you mad. So we're going to take a real quick second, just kind of recognize the medical community, especially like the CRNAs, because I've met amazing ones. In my practice, I'm going to speak for ACPS, and our practice is we have a great relationship with our anesthesia providers. It's a very special group of anesthesia men and women that we've worked with for, I think our average tenure with you guys, I think like 8 years or 10 years, something a long time. A lot of seniors have a lot more of the newer guys like you, And you've been with us for what, 5 years, something like that?
About 5.5 now.
And for us, all ACPS surgeons, we just feel safer. We want to be in the safest environment possible. And for us, we trust our anesthesiologists that are good friends of ours, and we feel that safety is most important. So, for us, it's really a surgeon preference. I'm not going to say that CRNA is inadequate. I'm just going to say that it's surgeon preference. And my preference is if something hits the fan, I feel much more comfortable with not just one anesthesiologist taking care of my patient, but I actually have 3 other anesthesiologists next door to me that would literally come running. They come running. And you have all that experience, all that education, all that expertise really trying to help in a worst case scenario. And that's what we don't want at ACPS. We don't want worst case scenarios. And we set that up obviously we screen our patients. Our anesthesia team is already, screening them and pre-oping them and making sure everything's done safely. So again, it's not, this is cosmetic surgery. No one's making you have the surgery. It's not emergent. It's just not worth it. So for us, again, it's safety. So I would say you agree with that.
I do agree with that.
Even though it costs more money, it does cost more money, and the procedure does cost more. I'm taking home less money because I'm choosing to use anesthesiologists. I could take home more money if I use a CRNA. That's kind of the reality of it. But again, I think it's worth it.
And I do think that the setup we have at ACPS is second to none, and it is true. I've learned a lot from the other docs, and they always have your back, and I go and support them whenever I need to. I have gone in and have had to help them before in the past, and even that is extremely unusual at ACPS. That's very unusual, and half the time we'll call each other in because I'm like, I just want you close by just in case.
Right.
And then nothing happens.
Right.
And then we all go back,
Right.
So, but I also want to qualify that I don't want anyone to think that I don't respect CRNAs. I have nothing but the utmost respect for CRNAs. Everyone that I have known, that I have, built a relationship with, are extremely hardworking, extremely intelligent, extremely good at what they do. And I know several that I would allow to put my children to sleep.
Yep.
So I do want to qualify that.
Agreed.
So
for us at HPS, it's a relationship, and we feel very, very comfortable with our team of anesthesia. And I just feel my patients are in the safest environment possible.
I do, because we want our surgeons to operate. Like, we want them to operate, and that's one thing that we love. That's one thing we love is that our surgeons provide these beautiful results to our patients, and I don't want them worrying about, is the patient okay? Is the patient okay? I feel that our surgeons generally know their patients are okay with us. And, especially, I don't look as young as I used to, but when I was first out in training and I looked a lot younger, I'd have surgeons all the time. Is the patient okay? Do you need help? Do you need help? Surgeons are very concerned about the safety of their patients. And as ACPS surgeons are no exception to that. They're very concerned. And if they can surround themselves with professionals to take that concern away, they can just do better for their patients.
Function so much better when I am comfortable,
Yeah.
And I hear these sounds, and these weird sounds, people don't think I'm listening, but I'm actually listeing.
I know you're listening. I know. And he's not the only one. He's not the only one that's listening.
But that's just kind of my job. Like it's some people ask me, how am I able to kind of listen and pay attention to what's going on in my room? Because it's just, I just do. It's just, I've been trained like that. It's what we do as surgeons, So, and anesthesia is our right hand. So it's so important for me, for comfort and for safety too.
Well, and we recognize that the buck stops with the surgeon, right. and with me to a degree. Sure. That with the surgeon and the anesthesiologist, the buck stops with there. If stuff starts happening, everybody's going to look straight to us.
Yep.
And so you better be ready, and you better have somebody who's comfortable, ready to do something about it. And I know all of our people
We're ready.
Can do it.
Great team, great facility. So let's talk about, as we kind of start winding this down, and we'll talk about some of the common side effects that are myths from anesthesia. And I had a patient ask me, told me that her mom had anesthesia and all her hair fell out. Is that true?
I've not heard of that. Their hair falling out. The most common side effects are nausea and vomiting, pain from the procedure, and
maybe itchy throat sometimes.
Itchy, scratchy throat. Itching, scratching from having itchiness, generalized itchiness from medications is relatively common. Sure. And constipation is
narcotics, right?
From the narcotics, but also the anesthesia itself can cause you to be constipated, and just generally undergoing surgery causes your bowels to slow down.
Sure.
So when we were talking about how can you ready yourself for anesthesia, one thing you can do for yourself is stay very well hydrated. That will help with nausea up until the point where you're supposed to stop eating and drinking. So try to stay as hydrated as you can. Try to keep your bowels moving as best you can. If you need to start taking, high fiber diet, taking fiber, I love milk and magnesia. I think milk and magnesia has a lot of great things about it. I tell patients, even the next day after surgery, something needs to be happening. Even if you're just nibbling, something needs to be happening, because if you get bloated, it's very uncomfortable.
Yeah, for sure.
So I tell, just go get over-the-counter milk and magnesia, chug it. You almost can't overdose on that. So, that's the other thing. So constipation can be a problem. Sure. And if you've had a tummy tuck and you get bloated, you're
really uncomfortable.
Very uncomfortable. And so those are the most common. One of the more serious side effects of anesthesia is confusion, delirium, and what we call cognitive dysfunction, where people will have a less executive function for a while after anesthesia.
That's FAQ for me, is like, how long does anesthesia last after surgery?
So generally, after general anesthesia, you are pretty awake. You generally, depending on, it depends.
Your favorite word, depends.
Depends. It depends. If you are leaving, if you're having a very short procedure, like if we're just doing breast implants and it's going to be a short procedure, they will probably be back to normal within 2 or 3 hours after they leave. If they are getting a big mommy makeover and they're staying overnight, that's going to be a lot more painful. So they'll get probably a lot more pain medication. Right. They'll be sleepier for longer. They're going to sleep longer. So it depends. And those are all questions that they should ask their provider at the time, because it's very dependent on what is happening. Yeah. And so, but if so like I said, it depends. Cognitive.
Again, these are questions you ask when you meet your anesthesiologist.
When you meet your anesthesiologist, ask, how long is it going to be before I'm awake? I had a patient, I don't remember if it was your patient actually, that one thing that was a very big distress to her was that she felt she was too sleepy when she was discharged. Even though with the thing with anesthesia is that you may not be sleepy, but you just might not remember being awake. Right. So even when I explained that to her, though, she still found it very distressing. So I
get that coming all the time. I've gotten complaints at the first visit, and they're like, surgery went fine. I know everything went great. I feel good and everything right now, but I just felt like I was pushed out. Mm-hmm. And it was too quick, and I wasn't fully with it, and y'all just threw me out. I was like, that's not true, because you were actually in our recovery unit for an hour and a half.
Yeah.
And you were there longer, just kind of keep you comfortable, and we don't let you go until you meet certain criteria to where you're able to go home.
Absolutely.
So you might not, we feel like you pushed you out, but in reality, you actually had quite a little bit longer to recover in a safe manner. We did this for safety, but they don't remember any of that, right?
Yeah, that's the problem.
They have this misconception of time. They lose sense of time, right?
Yes, that's very common, especially when you're receiving, because once you get to the recovery room and you're starting to wake up, your memory is also a spectrum.
Right.
So you're not necessarily remembering yet, but you're still awake. I
have full-out conversation with the patient. They remember nothing.
And they don't remember anything. That's very, very common.
Yeah.
So, they need to be rest assured that there are very specific criteria that patients have to meet before we can discharge them. And in no way, if we have any question, we keep them longer.
Correct.
Our staff is fantastic at saying, you know what, they're not ready. Right. And we've had nurses tell us they're not ready. They need to be here a little longer, and they stay longer. And so, but the problem is that the patient doesn't remember. So they feel like they were woken up and pushed out the door, when that's not the case at all. And but if I've had patients express that to me. So then I actually will take extra steps and to try my very best that they wake up a lot faster.
Sure.
In the recovery room.
Sure.
And that may involve receiving less pain medication. Right. Because in the recovery room is while they're waking up, they're saying, "Oh, well, yeah, my tummy tuck's really hurting. My breast implants are hurting. When you're having
compromise something else."
Yeah,
right?
so they're hurting. So they will receive pain medication in the recovery room. That pain medication is going to add to that amnesia. Sure. Generally, it's going to make them sleepy again. It's going to cause you to have amnesia. So there is a balancing act. We can't send people out in excruciating pain either. That's not going to be.
That doesn't work.
That's not good either. So we can't send them out in pain, but they will be awake and they will probably remember. But we have to do a balancing act. And then we try to explain that to patients. Generally, patients, they understand that. They get it. Some people still find it very distressing. And so we can try to have them more awake. I just want to say that anesthesia given by an appropriately qualified provider is extremely safe in general terms. You can Google, if you start Googling it, you are going to get nothing but horror stories. And I really discourage patients from doing that before surgery. I don't think that is productive at all.
It increases their anxiety.
It causes anxiety. And people need to realize that people put things online in order to get attention, to get views. They're not going to put that, I just had the most uneventful anesthesia on there. Right. Because that doesn't get attention. Do horrible things happen? Yes, they happen. But when you take into account the amount of anesthesia that is performed just in this country on a daily basis, right, and the amount of actual bad things that actually happen, it is so very safe. It is one of the safest things that we do. But it is very anxiety provoking. And I just hope that what we've done here today has alleviated some anxiety, and that I want our patients at ACPS to know that we are always available for questions. Mm-hmm. So if they ever have questions, that talk to the staff at ACPS. If there's a question that the ACPS staff here in the clinic cannot answer, they know how to get a hold of an anesthesiologist to answer any question that they're not able to answer. And we will always be available for questions.
Yeah. Thank you for hitting that point home, because that is just so important for people to kind of hear that and be reassured.
Yes, so I hope so.
I just don't think, I've already looked actually on YouTube, like how many conversations you've had with anesthesiologists about talking about this specifically, and there's not many. And so I'm hoping that my patients will be able to kind of learn about the risk of anesthesia, kind of what to expect, how safe it is, how safe it is. I promise you it's safe. Especially in our practice, but in overall, the anesthesia experience shouldn't be, hopefully nothing you should be totally anxious about, and it should be pretty much uneventful. That's exactly what I would say. It's going to be most likely uneventful. So just rest assured, if you have a great anesthesia provider and you trust your surgeon and you trust you hopefully going to be operating in an appropriate facility, that again, you're going to have an uneventful surgery and you're going to have a safe surgery and you'll get home as quickly as possible, as safely as possible.
That's always our goal.
That's the goal. So I just want to thank you again for your time.
Thank you for having me. This was so great.
She's one of my favorites.
Thank you. Thank you.
I'll say it on camera.
Oh, thanks. I have to admit, Roland's one of my favorites too. It's been,
But it's a great relationship. I love working with you.
It is a great relationship.
Thank you again for taking such great care of my patients. Always sleep better knowing I'm going to have you in my room the next day.
Oh, thank you, Roland.
I feel better going home. I'm not worried about who's going to be over and not going to have a problem, because I always know you kind of have my back with my patients. So again, thank you for that.
Thank you, Roland. Thank you. I find you and ACPS to be truly a blessing to work at. Thank you.
So anyway, we're ending the podcast here. I hope you learned something. All my followers here, please like, share, subscribe. If you have any questions related to anesthesia or just have a comment in general, just put a comment on the comment section below. Please follow me on FitDoc Productions, on my Instagram, Dr. Morales_FitDoc, and don't forget, like and subscribe. Stay tuned for more, and thank you for following.